Good morning. We're going to use these sessions to go over anatomy, gross anatomy, embryology, and radiology. Now, in the time that we have available to us, obviously we can't go over everything there is to know about anatomy, and that's not what our intention is. Our intention is to go over those aspects of anatomy and development that are critical for the USMLE, the so-called high-yield material. Now, fortunately, as you probably know, it's fairly easy to recognize what topics in anatomy are more likely to appear on the USMLE, because now the USMLE questions are largely written as clinical vignettes. So basically you can say that those elements of anatomy, those topics in anatomy about which it's fairly easy to think of something clinical to say, are the things that you need to know about. On the other hand, if you had to think long and hard about something to say clinical about some topic in anatomy, nobody's going to write a question about that because it's simply too hard to think of something to ask. So we're going to approach anatomy from a pretty clinical perspective. I think you'll see that as we go along. We're also going to do embryology, or development. Now, we're, for the most part, not going to do embryology as a separate topic, but rather we're going to integrate it with the anatomy. And so that as we're going over the anatomy of the heart, for instance, that's when we'll do the development of the heart and congenital defects relating to the heart. When we go over the abdomen and the GI tract, that's when we'll do the embryology of the GI tract. So we'll be able to see how the adult structure came to be as it is from the development. And it makes it easier to learn both topics in that way. Now, in order to do that, what we're going to be doing each time we want to come and take a look at how a particular organ or organ system develops, we're going to go back to the 4-week-old embryo and take some part of that 4-week-old embryo and bring it to the adult. So what we're going to do at the very beginning is deal with the issue of how do you get to be a 4-week-old embryo? What happens from the beginning, from gamete development and fertilization up through 4 weeks? And then we'll leave the embryo at that point and come back to it several times over the course of our discussions in different parts of the body. And lastly, we're going to do some radiology. And it's really important that we do that, not only standard radiography, but also, and in particular, CT, computerized tomography and MRI. For quite a few years now, there have always been CTs on the USMLE, and so it's really important that you feel comfortable in reading a CT and being able to identify normal structures on CTs. And so the way we'll do that is when we complete a region, like when we're all finished with the thorax, we'll go back and review the thorax using CTs to review the thorax, and that will serve us as both a review of the thorax as well as give us practice in reading CTs. Okay? So let's start at the beginning, as they say. And we're going to start on figure Roman 2:1:1, development of testes and ovaries. Now, the important point to recognize here is that the germ cells, the primordial germ cells, the cells that will eventually divide and differentiate to become sperm or eggs, don't initially develop in the region where the gonad develops, but rather these cells develop in the yolk sac of the embryo. The cells then migrate from the yolk sac into the embryo and then come to reside along the region of the back wall of the abdomen in the embryo that's going to be called the gonadal ridge. And that gonadal ridge, once populated by these germ cells, will then differentiate into a gonad. Without the germ cells migrating into the gonadal ridge, it won't become a gonad. Which gonad it becomes is going to be determined based upon certain factors that are synthesized by the embryo if it's a male. If this embryo has a Y chromosome, then a factor known as testes determining factor is secreted by the embryo, and that will cause this gonad to become a testis. In the absence of that Y chromosome, and therefore in the absence of that factor, this gonad will become an ovary. So you don't need any factor to become an ovary. In the absence of a testis-determining factor, it becomes an ovary. At the same time, there's another factor called Mullerian inhibiting factor, which males secrete, and that factor inhibits the development of the female genital duct system. So the embryo, in the absence of these factors, will become female. In the presence of these factors, will become male. Okay? So these primordial germ cells come to inhabit the gonadal ridge and thereby differentiate that ridge into either a testis or an ovary. These primordial germ cells, we're now on figure 2.1.2. These primordial germ cells will go through a series of divisions and ultimately into two what are called reduction divisions through the meiosis process to give rise to germ cells that have half the chromosome complement, in other words, the haploid germ cells. Now, a point to remember is that this process of meiotic division to give rise to germ cells in males does not begin until after puberty. Prior to puberty, there are no meiotic divisions, so there's no production of sperm. In females, the beginning of the meiotic division process begins actually before birth. And these primordial germ cells go into the first meiotic division, and they arrest during that first meiotic division and remain in that condition from prior to birth all the way on up through puberty. So the female germ cells are in an arrested state all through early life. After puberty, one per month, typically one, sometimes more, but typically one per month of these arrested germ cells will then complete that first division, enter the second meiotic division, and will then be ovulated and will go down the uterine tube. It will only complete the second meiotic division if it is fertilized. Okay? And if fertilized, that cell, which has now completed its second meiotic division and therefore is an ovum, immediately becomes a zygote, immediately has been joined already by the sperm. Okay? So that in reality, there never really is an ovum. The cell that is fertilized by the sperm is actually a secondary oocyte, which is in the process of becoming an ovum. It will complete that process only if it's fertilized. Okay? Okay, so we now have the development of the two germ cells, and we've begun to talk about this process of fertilization. So going to figure 2.2.1. We have the secondary oocyte, as I said. It's not yet an ovum. The secondary oocyte has been ovulated by the ovary. It has been picked up by the fallopian tube, and it begins the process of moving down the fallopian tube. Sperm have been swimming up the fallopian tube, and fertilization typically occurs at the distal end or the ampulla of the uterine tube. Okay, fertilization occurs. Once one of these sperm penetrate, then the secondary oocyte completes that division and unites with the nucleus of the sperm, giving rise to now a diploid again zygote with obviously half the chromosomes from the sperm and half from the oocyte. Okay, and so now we have that zygote. The zygote continues to migrate down the uterine tube over a period of several days. In the course of migrating down the uterine tube, it begins to divide. And these are called cleavage divisions. And they're called cleavage divisions because what's going to be happening is as the cell is dividing, each of the daughter cells becomes approximately half the size of its mother cell. So now we have two cells that together are approximately the same size as the one cell. When they divide, we'll have, let's say, 4 cells, which all together are about the same size as the 2, and so on. So this developing embryo is not getting larger at this point. It's just developing more cells, each cell being smaller. After a few days, we have a ball of cells called a morula, and then the cells of that morula start to rearrange themselves so that there develops a cavity within that ball, and that cavity is called a blastocyst cavity. The structure is called a blastocyst. Once we have a blastocyst, we can identify 2 parts of this developing embryo. This inner part, which we call the inner cell mass, that's what's going to actually become the embryo. And the outer part, which is not going to become the embryo, but rather that's going to become the extra embryonic membranes, and things like the amnion and the chorion and part of the placenta. Okay, so the actual embryo itself is only developing from the inner cell mass. Actually, a fairly small minority of the total number of cells. By around the 6th day after fertilization, this embryo, which is in the blastocyst stage, reaches the uterus and implants into the wall of the uterus. Notice that when it implants, the side of this blastocyst that contains the inner cell mass is the side that is toward the surface of the endometrium of the uterus, and it's on that side that it implants. And you can see the beginning of that implantation here, with those outer cells starting to differentiate into what will become the placenta and the extraembryonic membranes. Okay? And this inner cell mass will become the embryo. So when we're at that stage, we're at about a week into development. Continuing on into the 2nd week, cell division obviously continues. And here are many of those outer cells that are differentiating. And we're not going to spend any time talking about that. I want us to concentrate on these cells here, which were the cells of the inner cell mass. And you can see that those cells have now arranged themselves into 2 layers of cells. An upper layer, which is given the name epiblast, and a lower layer, which is given the name hypoblast. So we have a 2-layered embryo, the epiblast and the hypoblast. And in fact, it's going to turn out that the entire future development of the embryo is going to arise from only the epiblast. The hypoblast cells will eventually be replaced. Okay? So that's during the 2nd week, we then can say that we have a 2-layered embryo. We're going to then move on during the 3rd week into a 3-layered embryo. This is figure 241. And here we are with that 2-layered embryo again. And what's going to happen is 2 things. Firstly, some of these epiblast cells are going to migrate downward and replace the hypoblast cells. So when we take a look at this, which is a little bit further into development, here is the epiblast, and now we have these cells that are in a position where the hypoblast had been. These are now the definitive endoderm cells. So the endoderm cells that have replaced the hypoblast cells actually arise from the epiblast, have migrated down, and have become the inner layer. And at about the same time, other cells from the epiblast also migrate down, and they end up taking up a position between the upper epiblast and this lower hypoblast, and they end up occupying the space that's being created between those 2 layers. Okay? And those cells will then become the middle layer of the embryo, and they will be mesoderm cells as well as notochord cells. So we call that layer the chordomesoderm layer, combination of notochord and mesoderm. Okay? And so we will end up with a three-layered embryo. What we had been calling the epiblast we'll now call the ectoderm. We already said that this is going to be the endoderm, and in between we will have the mesoderm. We will see as we go on later that the endoderm cells are going to give rise to the inner lining of the gut tube, as well as the inner lining of the respiratory system, as well as the inner lining of part of the urinary tract. Okay? But just the inner lining cells, the epithelial cells, as well as the ducts derived from those cells. The ectoderm will, in large part, become the outer layer of the embryo, the skin surface, again, but just the outer layer, the epithelial cells of the skin, as well as the glands derived from that, such as sweat glands and salivary glands. Okay? And virtually everything else will be coming from this middle layer. Okay, so all of the connective tissue, muscles, bone, all of that stuff is going to be coming from the middle layer, the mesoderm. Now, the only other component that I haven't mentioned is nervous system. After the mesoderm and the notochord cells take up a position in that middle layer, those cells will induce some of these ectoderm cells in this region here to differentiate into the nervous system. They'll become what's called a neural tube, along with neural crest cells. And we're not going to talk about that now. That will be dealt with in the neuroscience section of the course. Okay? So for leaving aside the nervous system, we can say that the epiblast or the ectoderm will give rise to the outer layer, the outer surface of the human. The ectoderm will give rise to the inner surface of the structures inside of us, the GI tract, the respiratory system for the most part. And everything else in between is derived from the mesoderm. Okay? And in your notes, there is a table 241, which sort of lays out the adult derivatives of each of the major systems. And when we look at the ectoderm, you'll notice that when we talk about the skin, it's not the entire skin, but just the epidermis of the skin, as well as structures derived from that, like hair and nails. Okay? Not the entire tooth, but just the outer surface of the tooth, the enamel. Okay? And so on and so forth. Glands derived from that surface, parotid glands, salivary glands, mammary glands. Okay? When we talk about the derivatives of the endoderm, notice that it's not the entire GI tract, but just the epithelial lining of the GI tract and the epithelial lining of the trachea and the bronchi and the lungs, as well as structures derived from those linings, such as the liver and the pancreas and other glands. Okay? And then all of those other structures, the walls of these GI tract organs and the walls of the respiratory organs and so forth, the connective tissue and muscles of those organs, and all of the other connective tissue and muscle is coming from the mesoderm. The connective tissue underlying the skin is coming from the mesoderm. And then, as we said before, the nervous system and some other structures derived from neural crest are derived from that portion of the ectoderm that will differentiate into neural ectoderm and neural crest ectoderm as a result of the induction of the mesoderm and notochord cells underlying them. Okay? All right, so that takes care of the early embryo, and what we will be doing, as I said before, when we get to the appropriate points in the discussion of the adult, we will take some small portion of this, maybe a region here, or a region here, or a region here, and take that from this 4-week stage, end of the 3rd week, beginning of the 4th week, and bring it to the adult and see how it develops into whatever it develops into. All right, so now let's move on to adult gross anatomy. And we're going to start with the back. The back and then the nervous system. And I want us to start with the vertebral column. And we'll come over here and take a look at this illustration from Netter of the vertebral column in several different views. And let's first look at this anterior view of the vertebral column. This is looking at the vertebral column from the front. And what you are looking at in this illustration is fundamentally the vertebral bodies and the discs, the intervertebral discs between those vertebral bodies. That portion of the vertebral column has as its primary function the support of weight. That supports weight. That's what it's primarily designed to do. And keeping that in mind, you see that as we work our way down the vertebral column, notice that the vertebral bodies and the discs between them are getting larger and larger and larger the further down we go. Which makes sense, because the further down you go, the more and more and more superimposed weight has to be supported. But then notice that when we get to the top of the sacrum, at the level of the first sacral vertebra, and continue down, all of a sudden, that gradient we have been looking at, where it's been getting larger and larger and larger, all of a sudden very quickly reverses and starts getting smaller. Now, why should that be? Well, if the function of this is to support weight, that would say to us that the weight has gone away, right? Where has the weight gone? Well, right here, if you can look at the lateral view here, there's a joint. That joint would be the sacroiliac joint. So what's happening is that the weight is being transferred from the sacrum, part of the vertebral column, across the sacroiliac joint to the pelvis, and then on down to the lower limb. So once we get below this point, the vertebral column no longer is supporting weight. The pelvis and lower limb is now supporting the weight, and therefore the vertebral column very dramatically changes in structure and becomes smaller because it no longer has a weight-bearing function. Okay? So that's the front of the vertebral column. When we look at the back of the vertebral column, on this lateral view, this part of the vertebral column here, or on this posterior view, this surface, that has a very different function. That part of the vertebral column is primarily designed to protect the spinal cord. That's what it's there to do. It protects the spinal cord. It forms a bony wall surrounding the spinal cord. So what we have in the back of the vertebral column is there's a canal inside the vertebral column called the spinal canal or vertebral canal, and the spinal cord is going to be inside there. Now, since the spinal cord is inside the vertebral column, and the spinal cord is going to have spinal nerves emerging from the spinal cord that have to get out to the rest of the body, we need to have a way for the spinal nerves to get out of the vertebral column. And we do, and that is the series of openings that we see along the side of the vertebral column called the intervertebral foramina. So the intervertebral foramina are there to serve as exit points for the spinal nerves to get out. And so an important point to keep in mind is that what is actually living in each of those intervertebral foramina is a spinal nerve. The spinal nerve is actually in the intervertebral foramen, and that's going to be an important point for us. Okay? We'll come back to that in a few moments. A couple of other openings I want to point out to you while we have this illustration here. When we look at the back of the vertebral column, you'll notice that there are some openings between the lumbar vertebrae. Now, this part of the vertebra is called a lamina. That's a lamina, that's a lamina. So these openings that are between the laminae are called interlaminar spaces. Interlaminar spaces. And I'd like you to notice that the interlaminar spaces only exist at lumbar levels. At sacral levels, they don't exist because the vertebrae are fused together. So we don't have spaces. And above the lumbar levels, they don't exist because the laminae overlap one another, covering over those spaces. But at lumbar levels, we have interlaminar spaces. And that turns out to be important because we use those interlaminar spaces clinically for the purpose of doing lumbar puncture. Okay, so our access route for doing a lumbar puncture is the interlaminar space, which only exists at lumbar levels. That's why you can only do lumbar punctures. You can't do a sacral puncture or a thoracic puncture. Not that you would want to, but you couldn't anyhow. Okay? Now, since our objective is to get our needle through an interlaminar space, when we do a lumbar puncture, we want that space to be as large as possible. That's the target that we're aiming for, so we want the target to be large. So how do we get that target to be large? How do we get the interlaminar space to increase in size? we have the patient flex the vertebral column. And so the reason you do a lumbar puncture with the patient in a flexed position is to spread apart the vertebrae in order to widen the interlaminar spaces to give you a larger target. Lumbar punctures are typically done at the L4, L5 interlaminar space or the L5, S1 interlaminar space. A couple of important points to keep in mind about that. The landmark that we use to know where L4 is the top of the iliac crest, right here, what I'm palpating on myself. The top of the iliac crest is a palpable landmark on any patient. Even an obese patient, you can feel the iliac crest. And if you just draw a line across the patient's back from one iliac crest to the other, that line will go right across the L4 vertebra. So the interlaminar space right below that spine is the L4, L5 interlaminar space. Okay? The other point to remember is the reason we do lumbar puncture at that level is because we want to be below the bottom end of the spinal cord. We don't want to do a lumbar puncture where the spinal cord exists because that would damage the spinal cord. So the point to keep in mind here is that in the average adult, the spinal cord ends at about the L1, L2 vertebral level, somewhere around here. Remember, that's an average. So for any individual patient, you don't really know where the bottom of the spinal cord is. It might be a little bit higher than that, it might be a little bit lower than that. On average, it's right around here. So since for any individual patient, you don't know exactly where it is, and it could be as far down as here, to be sure that you're below it, that's why you come all the way down here to L4 and L5. This is even more important in children because at the time of birth, the bottom of the spinal cord is at the L3 vertebral level on average. Okay? So on average, in a newborn, it's around here. And as the child grows and the vertebral column gets longer, the spinal cord gets longer also, but the vertebral column gets longer faster. So it appears as if the spinal cord is rising in the vertebral column. But the point is that in children, the spinal cord comes down even lower than it does in adults, which makes it even that much more important to stay low in doing a lumbar puncture. Okay? The other landmark to keep in mind is that when we're doing a lumbar puncture, usually our intention is to get into the subarachnoid space where the cerebrospinal fluid is located. And so we need to know where the bottom of the subarachnoid space is. How far down does that go? And the answer to that is that on average it comes down to about the level of S2. So that when we do a lumbar puncture up here at about the L4, L5 level, we're above the bottom of the subarachnoid space, but we're below the bottom of the spinal cord. So we're in the region of the subarachnoid space that doesn't contain spinal cord. Okay? Last point I want to make on this illustration is that there's one more opening you should know about, and that's this one right here at the very bottom on the posterior surface of the sacrum. It's called the sacral hiatus. The sacral hiatus. It's also palpable. You can feel the two lateral borders of it and put your finger right onto the sacral hiatus. And you can slide a needle up into that sacral hiatus. And that's called using the caudal approach. The caudal meaning from the tail end. Okay? And when you pass a needle up through the sacral hiatus, you're passing that needle into the epidural space. Because remember, the subarachnoid space only comes down to here. So you're not going to get into the subarachnoid space this way. You're going to be outside the dura, and you'll be in the epidural space. And remember, the epidural space does not contain CSF. The epidural space contains a lot of fat and a lot of veins, but not CSF, not cerebrospinal fluid. Okay, so let's move on. And on this illustration, you can see very nicely the fact that coming out of the intervertebral foramen at each level is a spinal nerve. And in a few minutes, we're going to be talking about the boundaries of that intervertebral foramen to take a look at what kinds of disease processes can affect that spinal nerve as it's occupying that intervertebral foramen. Okay, we'll come back to that. So now let's talk about the spinal nerve that we've been referring to. The spinal nerve on this diagram showing two spinal nerves. The actual spinal nerve itself is only this short segment right here. That's the spinal nerve. Only from here to there is spinal nerve. Nothing else. The spinal nerve is formed by two roots, a dorsal root and a ventral root. Those two roots come together to form a structure called the spinal nerve, and then very quickly, after about 1 centimeter of length, the spinal nerve divides into two branches. Those two branches are called the rami, the dorsal and ventral ramus. Now, we know that the dorsal root contains sensory fibers, and the ventral root contains motor fibers. Those two roots come together to form a spinal nerve, so the spinal nerve contains both sensory and motor fibers. When the spinal nerve divides into two rami, both kinds of fibers go into both rami. So both the dorsal ramus, or posterior ramus, and the ventral or anterior ramus, both of them contain motor and sensory fibers. The reason the spinal nerve is dividing into two rami is to go to two different parts of the body. The posterior ramus is going to go to the posterior part of the body, and the anterior ramus is going to go to the anterior and lateral parts of the body. Now, you'll notice that the posterior ramus is much smaller than the anterior ramus, and that's always the case because there are far fewer things that get innervated by posterior rami. So it's useful to simply know what does the posterior ramus innervate, and then you'll know that everything else is the anterior ramus. So the only things that the posterior ramus innervates are the skin of the back, the deep back muscles, and the synovial joints of the spine. That's it. The skin of the back, the deep back muscles, and the synovial joints of the vertebral column. Everything else that gets spinal nerve innervation gets it from the anterior ramus. Okay, now let's come back to these roots. We see that the dorsal root has an enlargement on it, a bump. That bump is called the dorsal root ganglion. Now, there is an illustration in your notes that we can refer to at the same time, figure 315. Okay, and so there's that dorsal root ganglion on the dorsal root. Now remember that the word ganglion simply means a group of nerve cell bodies in the peripheral nervous system. A group of nerve cell bodies in the peripheral nervous system. That's what a ganglion is. And I point that out because it doesn't say anything about what kind of nerve cell bodies. And over the course of our discussion, we're going to come upon different ganglia in different parts of the body that will be different from one another. They'll have different kinds of cell bodies in them. Some will be sensory and some will be motor. In the case of the dorsal root ganglion, the cell bodies that are in it are sensory cell bodies. They are the cell bodies of the sensory fibers that are found in the dorsal root. We're also going to find that some ganglia have synapses occurring in them and other ganglia don't. In the case of the dorsal root ganglion, there are no synapses. Okay? So the dorsal root ganglion is simply the location where the cell body lives. No synapses occur there. And you can see that very nicely on that diagram. Okay? Now, when we look at the ventral root, we'll notice that there is no enlargement on the ventral root. There is no ventral root ganglion. So the obvious question is, where do those cell bodies live? Where do the motor cell bodies, the cell bodies of these motor fibers, where do they live? And the answer is, well, they're not in the peripheral nervous system. They're back here in the spinal cord. They're in the central nervous system. So the cell bodies of the motor fibers are in the gray matter of the spinal cord. Since they're inside the central nervous system, you don't call that a ganglion. That's called a nucleus. So this would be the anterior horn nucleus. That's where the cell bodies of these motor fibers live, in the spinal cord. Okay? So there are the sensory fibers, there are the motor fibers. They come together. The spinal nerve contains both kinds of fibers. And then, as I said, both kinds of fibers go into the ventral ramus, and not shown on this diagram, but also true, both kinds of fibers will go into the dorsal ramus to go to those parts of the body. Now, let's come back to the issue of the spinal nerve living in the intervertebral foramen that we looked at before. And I want to use figure 313 to look closely at an intervertebral foramen. What we're doing here is we're taking one of these intervertebral foramina that we see here and just blowing it up. And we're just looking at the two vertebrae on either side of that intervertebral foramen. Okay, and these two illustrations are reversed from one another. So this is the anterior side. There's a vertebral body. There's a vertebral body. There's the intervertebral disc between it. And then here's the intervertebral foramen between the two vertebrae. And we know that a spinal nerve will be passing through that. So what we need to pay attention to is what's forming the boundary of the intervertebral foramen. And of very great importance is the fact that a great deal of the anterior boundary of the intervertebral foramen is formed by the intervertebral disc. Part of the anterior boundary is formed by the body of the vertebra above. A little bit of it is formed by the body of the vertebra above. And a significant portion is formed by the disc itself. And you can certainly see that on this diagram, that the disc is forming part of the anterior boundary. That is important because intervertebral discs sometimes herniate. Or to be more specific with our language, the nucleus pulposus, which is the central gelatinous portion of the disc, herniates out of the surrounding annulus fibrosus. So it's called a herniated nucleus pulposus. When a nucleus pulposus herniates, almost always, about 95% of the time, the direction of that herniation is posterolateral. Posterolateral. Because the other regions of the disc are reinforced. The anterior, the lateral, the posterior surfaces of the disc are reinforced by strong ligaments. But the posterolateral surface of the disc is not reinforced by ligaments. And so that's the weak part of the disc, and that's where the nucleus pulposus herniates. Why is that important? Because if you look to see what is posterolateral to the disc, you find that that's where the intervertebral foramen is. So that means when a nucleus pulposus herniates posterolaterally, it's herniating into the intervertebral foramen. And we've already said that there's something living in the intervertebral foramen, which is the spinal nerve. And so now what has happened is that the herniated nucleus pulposus is occupying space in that foramen, space that the spinal nerve might like to be occupying. So the foramen has gotten too crowded. It pushes the spinal nerve out of the way. If that herniated disc becomes large enough and pushes the herniated nucleus pulposus becomes large enough and pushes the nerve far enough, the nerve will get pushed up against the bony wall of the foramen, can't get pushed any further, and it will get compressed against the bony wall of the foramen. And it's that compression of the spinal nerve by the herniated nucleus pulposus that results in the symptoms that we associated with herniated discs. Now, the sensory symptoms as a result of the compression of the sensory fibers in the spinal nerve, and the motor symptoms, muscle weakness, and so forth, associated also with the compression of the motor fibers of the spinal nerve. Okay? Now, when we look at the posterior wall of the foramen, we see that it's being formed by the region where the two vertebrae are coming together. You can sort of see that over here, not as well. That's where the so-called articular processes or articular facets of the adjacent vertebrae are articulating to form a synovial joint. Remember, those are the synovial joints that we said are innervated by dorsal rami. These joints have names. They're called the zygapophyseal joint. That's not the important thing. The important thing is that these joints are subject, like other joints in the body are subject to pathologies, including most particularly osteoarthritis. And when these joints become osteoarthritic, one of the characteristics of osteoarthritis is the development of osteophytes, bone spurs. And so if you develop bone spurs on this articular surface, any of those bone spurs that emerge anteriorly from the joint are now occupying space in the intervertebral foramen. And so all the things that we said a few minutes ago about a herniated nucleus pulposus occupying space in an intervertebral foramen, we can repeat them all over again, because now these bone spurs can compress the spinal nerve and result in the same symptoms that we talked about. So the symptoms that we're seeing are really not disc symptoms or joint symptoms, they're really nerve compression symptoms. The nerve compression, spinal nerve compression, is being caused by the herniated disc or the osteophytes of the zygapophyseal joint. Okay? All right. Now, let's come back and take one more look at the spinal nerve. And I want to point out to you that as we follow the roots back toward the spinal cord, we see that the roots break up into rootlets, and then it's the rootlets that actually attach to the spinal cord or emerge from the spinal cord. And I want you to notice that the rootlets from this spinal nerve and the rootlets from this spinal nerve don't overlap. There's a region of spinal cord from which all of the rootlets of a spinal nerve emerge. And then there's the next region of spinal cord from which all of the rootlets of the next spinal nerve emerge. Those regions of spinal cord, a region of spinal cord from which all of the rootlets of a single spinal nerve emerge, is called a spinal cord segment. That's what the definition of a spinal cord segment is. A region of spinal cord from which all of the rootlets of a single spinal nerve emerge. Now, let's carry that thought one level further. We have many spinal nerves. We have 31 pair of spinal nerves. The spinal nerves are going to be named according to which intervertebral foramen they pass through. And if we come back and look at this, we see that the spinal nerve is passing through a foramen, and that foramen is between two adjacent vertebrae. And the spinal nerve is named according to that foramen. The rules that we use for naming are two different rules. We use one rule for cervical levels, and we use another rule for all the other levels. So let's do all the other levels first, since we have a lumbar picture here. At thoracic, lumbar, and sacral levels, the spinal nerve is given the name of the vertebra above the foramen. So in the case of, let's say, this nerve, which is passing through the foramen between L4 and L5, that nerve would be called the L4 spinal nerve. It's given the name of the vertebra above the foramen. And that's true at sacral levels, at lumbar levels, and at thoracic levels. At cervical levels, the rule is just the opposite. At cervical levels, the nerve is given the name of the vertebra below the foramen. So the nerve that would be passing through the foramen between C4 and C5 would be called the C5 spinal nerve. Okay? So that's the rule for cervical levels. The other is the rule for all the other levels. Once we have a name for the spinal nerve, we then use that same name, and that's the name we give to the roots from that nerve. So if, let's say, this was the L1 spinal nerve, then this would be called the L1 ventral root. That would be called the L1 dorsal root. These would be the L1 dorsal and ventral rootlets. And then this region of spinal cord to which the L1 rootlets attach is called the L1 spinal cord segment. Okay? So spinal cord segments are named according to which spinal nerve attaches to them. Spinal cord segments are not named according to where in the vertebral column they happen to be located. That's a separate issue. Spinal cord segments are named according to the spinal nerve attaching to them, and the spinal nerve then is named according to the intervertebral foramen it passes through. Okay, last quick point about the spinal cord. The spinal cord is surrounded by 3 layers of meninges. 3 layers of meninges. The innermost layer is called the pia mater. Now the pia mater is fused to the spinal cord. It's fused to the spinal cord. Cannot be separated from the spinal cord. It's a thin, transparent layer. When you're looking at a spinal cord, you're looking at it through the pia mater. Nobody here has ever seen a naked spinal cord. It's always got pia mater on it. You cannot remove the pia mater. Okay? The next layer outside of that is the arachnoid. Now the arachnoid is also a thin, somewhat transparent layer, but it's not fused to the spinal cord. In fact, there's a space between the pia mater that's on the surface of the spinal cord and the arachnoid, and that space is called the subarachnoid space, and that space contains cerebrospinal fluid. So the cerebrospinal fluid is in the subarachnoid space. And then outside of the arachnoid is the dura mater. Dura is not transparent. Dura is an opaque, tough, fibrous layer. The arachnoid is pushed against the inner surface of the dura. So those 2 layers are pushed together, so there is no space normally between the dura and the arachnoid. There is normally no space between the dura and arachnoid. So there is no subdural space. The only time a subdural space will be created is if there is bleeding into that cleft, and the blood would then separate the dura from the arachnoid, and the blood would then be in what it has just created as a subdural space, and that's what we would call a subdural hematoma. But normally, there is no space, okay? Because those 2 layers are pushed again. They're not fused, they can be separated, but normally they are not. Okay? Notice that as each of these spinal nerves are emerging, as they proceed outward and they reach the overlying layer of meninges, they have to push that layer of meninges ahead of it, so as they're emerging, they end up covered by those layers of meninges. So here, when you see the spinal nerve emerging, you see that evaginated and therefore covering the roots and the nerve and so forth are these layers of meninges that we just talked about. Okay? So that is the dura covering the spinal nerve. Here we've cut away the dura, there's the arachnoid, cut away the arachnoid, we're in the subarachnoid space, and we can see the spinal cord. Okay? And so when we put this all together in a cross-section, what we're seeing here is the spinal cord. You can't see the pia mater because it's fused to the surface of the spinal cord. Just outside of that, in this region that is shown as black, is the subarachnoid space. That's filled with CSF. Here you see the roots passing through that subarachnoid space. And then this would be the arachnoid and dura. Okay, and then outside of the dura, we have that epidural space. Remember we said the epidural space contains fat and veins, and that's what you see here, fat and veins. Okay, and then outside of that, we have the vertebral column. So when we want to do a lumbar puncture to get to where the CSF is, now we wouldn't be doing it at this level, right? This is too high, the spinal cord here. We'd be doing it lower down, so it's below the spinal cord. But we would want to get into that subarachnoid space, so that means we would have to go through that interlaminar space that we talked about, into the epidural space, through the dura and arachnoid, into the subarachnoid space. Okay? Okay. So I think what we'll do is take a break there, and when we resume, we will continue to talk about the autonomic nervous system.